Thanks to everyone for joining. And tonight we're gonna talk about some interesting case discussions focused around spinal deformity with Dr. Schwab, myself, and Dr. Virginie Lafage, followed by a couple of articles presented by our stellar fellows. And after that, we'll go through a couple of cases and try to spur some discussion. If you have questions during the presentation or if you need any help troubleshooting, you could always use the chat box. We have the outstanding administrative staff of the Seattle Science Foundation on with us. And with that being said, I'll start out with Dr. Lafage's presentation.
Thank you very much. So my task is to talk about the principle of skeletal alignment in a few minutes. But don't worry, I'm not going to bombard you with a ton of parameters because that's what we do on a regular basis, and we end up losing everybody. And so after usually a presentation with a lot of parameters, people jump from the believer to the non-believer category, and they don't want to hear about those parameters anymore. So the question that I want to try to address is how does everything fit together? How can we have a standing posture? And I'm going to talk about the pelvis because at the end of the day, the pelvis is the foundation of the spine because the spine is not floating around. It sits on something. And I'm not going to tell you a lot about the parameter, but just look at this shape. So this angle is the pelvic incidence, but actually we don't really care. This is just something that measures the orientation of the sacrum within the ilium. So now think about the spine. The spine sitting on the sacrum. If you go from a low PI to a large one, right away you can visualize the spine, and you need different shape. So let me show you another illustration. Here you will have a large pelvic incidence, so an horizontal sacrum. What you need is big curvature, a large lumbar lordosis, a large thoracic kyphosis. On the other hand, if you have a small PI, well, you can have a flat spine, and that's perfectly appropriate. And so, this parameter, the PI, tell you how much lordosis a patient needs. So it's amazing, just by itself, one parameter is going to tell you about the shape of the lumbar lordosis. And if it was a TV commercial, I would say that's not all, because it's actually not all. The next step is what about the thoracic kyphosis? Well, the same principle apply. Now it's a kind of a chain of correlation. So the pelvis tell you about the lumbar spine. The lumbar spine is going to tell you something about the thoracic one. And so if you don't know where to start, thoracic kyphosis is equal to 2/3 of the lumbar lordosis. So here you have it. One parameter tell you everything about the spine. I mean, not everything, but a lot. But as spine surgeon, you're not dealing with normal asymptomatic subject. You're dealing with patient with a deformity, patient with a loss of lumbar lordosis, an increase of kyphosis. So as a general rule, most of the problem will lead to an anterior malalignment. So the spine tilt forward. If you have a schematic orientation, this is actually not possible because the trunk tilt forward and there is no compensation. You will need a walker. So the patient will compensate by turning the pelvis, flexing the knee. And so the compensation, what does it do? It brings back the spine in a vertical position. So of course, in real life, you have way more compensation, the pelvis, the knee, the extension of the spine, but it's all about the same objective, to bring back the spine in a vertical position. And so those parameters, it's not just a French fantasy. They actually matters because they correlate with patientreported.com. And so we can fight, and we usually fight a lot, on the podium. My parameter is better than yours, but at the end of the day, what do you need? You need to understand the shape of the pelvis. You need to know about lordosis, kyphosis, which you're already very familiar. And you need something to measure the truncal inclination. If you understand those key concepts, you can analyze any spine. You can analyze any spine because the skeletal alignment matters because it correlates with disability. It's very common, so deformity, but also degenerative population. The SAG has done a lot of work to demonstrate that it can help in mitigating the complication. So it's not a miracle. It's not going to help you for everything, but it does help. And at the end of the day, you just need 3 or 4 parameters and not the 20 or 30 parameters that we usually try to sell when we're on the podium. Thank you.
All right. Angela, do you want me to move ahead?
Yes, please, Frank.
I'm just trying to find the advance button on the bottom here. So I'm having
trouble. Dr. Laforge, if you could let go of the mouse, that would be great.
Aha! It's hooking the mouse.
Sabotage.
Yep.
Sabotage. All right. If you hand it over to me, just let me know once I should be seeing it.
Yep.
So Dr. Schwab is going to give us a presentation looking at how things have changed in the last 10 years in regards to his practice. Very interesting things that we've learned throughout the years.
Okay. So I'm still trying to get control of the mouse, and as soon as I have that, I think I can start. Could you just tell me where the mouse control is? Because I don't see it on my screen.
Yeah, it's the bottom left-hand corner there, Dr. Schwab.
It says mute, it says stop video, and I don't see it.
Oh, his Zoom bar is up. We got to take that off his screen.
Dr. Schwab, can you click on the slide?
Sure.
Yep.
Should I just click on slide to advance them then?
Mm-hmm.
Okay, perfect. All right, so I was tasked with talking a little bit about what I do routinely now that I didn't necessarily do 10 or 20 years ago, and that I think is a good routine or has helped me quite a bit in dealing with these complex patients. And so here's a case that, and I saw Steve Glassman on earlier. Here's my mentor that taught me a whole lot about spine surgery. You can just go back one slide. And that was JP Farsi. And we did a lot of osteotomies together, and it wasn't really fashionable back then. And really high blood loss surgeries. And these were surgeries that typically took us, 4, 5, 6 hours, and patients were intubated for 1 or 2 days. And then if you look at today in a case like this, it's rather routine that we do a PSL skin to skin. Takes us about half the time, or certainly less than before. The length of stay is about half what it used to be. And we managed to get our patients through with much more predictable outcomes. And what's changed is a lot of things. So I think important to note that, yes, our techniques have improved, but a lot of other things around us have improved that have made us get much better outcomes with these complex patients. And so I just want to touch on those individually. Virginie has already touched on some of them, but I think the key thing is that while the pathology is more evident to us and we understand its complexity more, a lot of improvements have happened outside the direct surgical arena, and certainly a multidisciplinary approach has helped us dramatically. So what Virginie touched on are these key parameters. So that's something that I didn't routinely do 20 years ago. 10 years ago, we started measuring things, and now it's a consistent part of our workflow that every single patient gets measured and analyzed. But beyond the basic measurements, as Virginie's pointed out, is the recognition that there is a fair amount of personalization that has to go beyond the initial approach of, well, what's my PI and LL and what's the ratio and where's my SVA? And so, as Virginie touched on one slide, you may have picked it up, is the high PA and low PI patients are very different. And that's that variability in relationship between lumbar lordosis. And the other is the thoracic kyphosis, recognizing that particularly in this older population, fixed thoracic kyphoses have equal weight as pelvic incidence in determining ideal lordosis. So a much more personalized approach than what we initially set out with the classification through the SRS. And then another layer on top of that is the age consideration. And that's something I do much more consistently now and didn't do even 5 years ago, which is setting the bar for realignment adjusted to age. And you can see that someone in their 30s and 40s has a completely different profile and a different goal than someone who's in their 70s. And now patients often come to us that are healthy in their 80s that want to have this kind of a complex surgery. So beyond that, and as we're talking about these increasing layers of complexity, is the distribution of lordosis. And important to recognize that the distribution isn't uniform. So a low PI patient, the majority of the lordosis is at L4 to S1, whereas a high PI patient, only half of it is in that area. And that I take into consideration when I plan my osteotomies, figuring out what level I'm going to get my correction. And so I take into consideration the pelvic incidence to determine where I will place a PSO. And it used to be everything was L3, and now many patients are L4, L5, and some of them in sacral osteotomies, again, taking this principle into account. Implants and instruments have changed, of course, so custom rods have helped us quite a bit to dial in ideal alignment for these reconstructions. I've changed my iliac fixation to be in line. I don't like S2AI, so direct S1 lateral approach, but gets everything in line. And we're using junctional transition tethers to buffer the junction. Here you can see an image of that. And I think critical that you tension those tethers and attach them to the rod and not just to spinous processes. And our early data seems to be very promising that this mitigates substantial failures. Even if you get a little settling at the junction, you don't get a lot of failures. So here's a patient that we can see that 74, that 20 years ago would have been a T2 to the pelvis. She's osteopenic. She's being treated for that. The surgical strategy here is short, leaving what was a big no-no many years ago, a kyphosis above the fusion, but a tether that went 2 levels above that, and then a contoured rod, and then an age-adjusted alignment goal. And she's over a year out and hasn't broken down. So I think we've gotten a lot better at reducing our fusions and targeting more age-appropriate alignment. A big area that's changed that we didn't do 10 years ago is every patient who is on opioids is now going through a chronic pain service. This is a slide courtesy of Ellen Sofin. We are doing erector spinae blocks. We have ARAS pathways, and I think Angela is going to talk more about that, and really have dramatically improved the recovery of patients going through complex surgery, and that gets them out of bed post-op day 1, and sometimes even the same day gets them sitting up, even if it's a T4 to pelvis, and gets those patients home in 4 or 5 days, what used to be a routine 10-day stay in the past. And then the post-op management here, talking about pain medication. And then finally, imaging and navigation. I'm a big proponent of new technology, and I think that robotics and navigation is not just for MIS. I think it plays a big role in deformity. Here's a patient that has wispy pedicles, and where I think you can also really gain time for pelvic fixation when you don't have to expose a whole lot. Once you trust the navigation and the robotics, then you really cut down the exposure time to get some of these implants into complex places. So thank you for paying attention to this. We have a debate later on, and I'll hand it over to Henjo now.
Thanks. And just to continue along the lines with what Frank was talking about, I'm going to give a little introduction to and the results of the HSS Expedited Clinical Care Pathway for reducing length of stay for adult spinal deformity surgery. So there's been a number of studies that have examined an enhanced care pathway for adult deformity patients or after major spinal surgery or adult scoliosis surgery, and nothing's been really consistent in regards to its ability to reduce the length of stay. And if we think about length of stay, it can be associated with increased complications, but also with increased costs. And in a cost-conscious healthcare environment that we have today, one of the goals is to try to reduce length of stay for these patients that would otherwise stay 7 to 8 days. So we sought to do a study looking at inpatient clinical care pathway that would be able to reduce length of stay for these patients undergoing greater than 5 levels of operative intervention for their deformities. The way that we designed the pathway was trying to attack 4 factors. One was blood loss. The other thing was operative time, avoiding ICU stays, and early mobilization. And some of the details in regards to that are a dedicated anesthesia team, which some of the details are having controlled hypotension during your approach, also giving an appropriate amount of paralytic during the approach to make your approach faster. decreasing your operative time by staging your surgery into 4 stages as far as strategy, making sure everybody in the room is on the ball with you in regards to the stages and where you are. Having a PACU for overnight monitoring, more so than a dedicated ICU stay for these patients. And early mobilization, which includes getting patients out of bed the first day in the afternoon after they're out of the operating room, mobilizing 3 times a day instead of just twice a day, and also with sort of a tailored pain medication regimen to include Toradol and dexamethasone. So we initially started out with a power analysis looking at prior data, and we thought that 26 patients would be necessary to detect the length of stay difference of 2 days. And just because we were hitting some research deadlines, we decided to try to do an analysis when we were at 20 patients. And these are the results from our preliminary analysis of 20 patients. So sort of hot off the press here that we're presenting. But basically, anybody who had 5 or more levels of fusion that were performed with the single-stage posterior approach were included. And we looked at these 20 patients and propensity score matched them 1-to-1 based on age and other demographic parameters, in addition to radiographic parameters and the type of surgery that they were going to undergo. This is some details on some of the intraoperative differences between the expedited pathway versus the historical cohort. And also some of the post-operative changes that have happened. So, for example, the use of ketorolac, and this gave us a little bit more confidence to utilize in these patients, especially because we saw favorable results in a randomized controlled trial that Vin was a part of here at HSS, looking at the utility of this in just regular lumbar fusion patients. But also, like Dr. Schwab was mentioning about the chronic pain patients, having chronic pain specialists on board and making sure their clearances are appropriate and their medications are adjusted appropriately. But other things like mobilizing patients on post-op day 0, like I mentioned, and having them out of bed with therapy 3 times a day instead of twice. You can see here that our propensity matching was effective, so no significant difference in the patient demographics for the variables that we listed here. But we were able to be effective in decreasing these 4 elements that we sort of attacked. So the blood loss was down by about half a liter. The operative time was down from 5 hours to 4.3 hours. And the ICU stay was down to 0% for these patients. And we were also, with the early mobilization, there was a greater number of people that got out of bed and actually walked on post-op day 0. So what we see is that not everybody gets up on post-op day 0 and actually walks. They may stand up. Some of them feel lightheaded. So, but what we do see is that just doing that in itself will make sure that the post-op day 1 ambulation is much, much higher than it was traditionally. And these combined things have brought our length of stay average down from 7.3 to 4.5 days for these patients. Other things that we saw was we didn't see any readmissions in this specific cohort, but there was not a statistically significant difference, but a difference in medical complications a little bit lower. Again, not statistically significant, but overall, no readmissions were noted despite using this pathway and an earlier discharge, which is often a concern with patients who get discharged early. And also, you could see some of the details in regards to bowel movements when they're off of their IV PCA and when they receive some of these adjunct medications for pain control, which included dexamethasone and Toradol. Some strengths of the study is that a pretty homogeneous population here in the same system with a single surgeon. And the pathway was not really expensive to implement. The sessions with physical therapy are pretty cheap. The medications were cheap. We did not have to hire any additional staff. We just redefined some of their roles and allocated some additional resources in regards to the mobilization for these patients. Some of the weaknesses here is that because the hospital is very guarded about some of their direct cost data, we were not able to directly evaluate that, but we could definitely generalize some of the study, some of the data to Medicare data, and maybe worthwhile to look into in more detail. Also, because of the system that we have here at HSS, some of the things in our pathway might not be generalizable. So basically, what we saw with this clinical pathway preliminarily is that we were able to reduce our length of stay about 38% with this approach. And it's something that in the future, we would definitely want other centers to try to adopt and see if it could be validated, because overall it's going to reduce it's going to reduce the cost of adult spinal deformity surgery. And in doing so, in the long term, we could potentially increase the cost effectiveness of the surgery. That's it. Thank you. So on that note, those are our presentations, and now we're going to go through some of the Journal Club articles, starting with our fellow first, Michael McCarthy. Michael?
Hey guys, I'm Mike. I'm one of the current HSS fellows. There you go. So I'll be doing the incidence and risk factors of postoperative neurologic decline after complex adult spinal deformity. So this is based on the Scully risk study. So this is a prospective international multi-center database. So it's a collaboration between SRS and also AO Spine. And they've combined both their data. And so the inclusion criteria for this specific study were those greater than 18 years of age and also adult deformity anywhere between C7 and L2 that was deemed complex. And so what they defined as complex was major coronal sagittal Cobb angles greater than 80, osteotomies, whether that was for congenital or revision settings, and those include either PSOs or BCRs, and also those who had myelopathy secondary to deformity. So they used the Asia Neurologic exam to define these patients, specifically with Asia certified examiners. And they had those examiners look at patients right before surgery within a 6-week window and then right at discharge. And so they scored it using the lower extremity motor score, which is L2 through S1 and 25 points per limb for a total of 50. So you looked at the pre-op x-rays, the upright imaging showing Cobb angles, thoracic kyphosis, lumbar lordosis, and also the deformity angular ratio, or the DAR, which is, if you don't know, it's just the Cobb angle of that focal deformity divided by the number of vertebral levels. And so they then divided their group into those who had a decline in the neurologic function, and then those who had either the same in the post-op setting or had an improved neurologic outcome. So 265 met the inclusion criteria with a mean age of about 57. The most common inclusion criteria for the surgery itself was a 3-column osteotomy, followed by those who had a revision setting with an osteotomy and those with a primary deformity greater than 80 degrees. Lumbar osteotomies composed about 73%, where thoracic osteotomies composed about 43%. So baseline scores, about 75% of those had very normal scores at 50. About 25% of the cohort had less than 50 scores. And 23% of those patients had a decline in their function at post-op. So 23 had a neurologic decline at discharge. It's important to note that the 7 of these patients initially went into the surgery because they had some type of neurologic complication pre-op. So that 23% number might not be an accurate portrayal. You can see the distribution of that in Table 2 for the specific levels. You can see L2 is most common, followed by L3, then L5. As far as osteotomies, you can see there was an association between the level of neurodecline and the same level for the osteotomy, but the odds ratio showed a 1.2 after adjustment for confounder. So we'll get into that a little later. So they used 10 variables existing in the current literature to avoid overfitting for the final model, which you can see in Table 4. And the univariable analysis showed that age, prevalence of lumbar osteotomy, and prevalence of 3-column osteotomy, in addition to blood loss, was difference between those who had a decline and those who did not. The multivariable analysis showed that older age, larger coronal DARs, and also lumbar osteotomies did have a significant difference and had a higher propensity in those who did have a neurologic decline. So in conclusion, you can see that it's fairly uncommon to have a neurologic decline in these complex surgeries, but the study found it to be about 23%. But if you look at the literature, it skews pretty high, so it's about 8.6 to about 40. They found that the key contributing factors leading to neurologic decline in these complex patients were older age, larger coronal deformities, and also lumbar level osteotomies. They found that L2 was the most common, and yeah, there was some association with the osteotomy side, but I think this is really overrated, and I think they also kind of highlight some of that, so it's not really something to hang your hat on. And some of the limitations are with this is that there's really no idea, even though they had a smaller number of thoracic osteotomies, no way to truly assess what the deficits could have been from that, since they just did the lower extremity motor scores, no sensory that could have maybe captured that. Also, these are really experienced and seasoned deformity surgeons, so I'm not sure if it really transfers to kind of lowly idiots like myself who might be doing this. And then also, these are fairly complex cases, and if you look at the other prior literature that involves these complex cases, it's not really clearly defined in those, so I don't know if it's really generalizable to kind of group this with some other information that we currently know. Thank you.
Okay, thanks, Mike. And then we'll get to our next article here with Phil Louie. Phil?
Yeah, great. Nice to see everyone here. Phil Louie here, one of those HSS fellows, here to help save you and solve your PJK woes. So this paper discussed using a combination of surgical implant prophylaxis as well as trying to avoid overcorrection of your sagittal alignment and how that contributes to the prevention of PJK. So as we know, proximal junctional failure, or PJF, is a severe form of PJK. And many of what's been presented in literature has focused on using surgical implants and different types of implants to prevent PJF. But there's less information out there that talks about avoiding overcorrection based on the age-adjusted sagittal alignment parameters that Dr. Schwab brought up earlier. As we also know, PJK and PJF are largely multifactorial, and lots of theories and solutions have been proposed. And the reported rates are all over the place as well. The rates for ASD reoperations or following ASD surgery was 20 to 40% as described in this paper. So the purpose of this paper was to evaluate if the surgical implant prophylaxis combined with trying to avoid sagittal overcorrection was more effective in preventing PJ failure than using just surgical implants alone. So this study was using the ISSG with 11 participating research centers. You can see the parameters for inclusion listed on the right and how PJ failure was defined. So in the upper thoracic and lower thoracic spine, if the proximal junctional angle was greater than or equal to 28 degrees, or the change in that angle was greater than 21.6 degrees, they were considered a PJF. Similarly, in the upper thoracic spine, if there was a spondy at that level greater than or equal to 8 millimeters, or in the lower thoracic spine 3 millimeters, then those were considered proximal junctional failures as well. So if we look at the patient population, they had 625 patients, and the groups were really split into two sort of categories. One was implant prophylaxis. Was there any effort in it, or was there a focus on implant prophylaxis? And if so, was it the use of cement, hooks, or tethers? And the second thought is, okay, well, let's look at the sagittal alignment. Are these patients within the normal alignment goals, or were they overcorrected based on these age-adjusted parameters? And then looking at the presence or the absence of implant prophylaxis with that. They used the propensity score match analysis to control for other PJF risk factors. So we look at the first set of results. They wanted to look at if the incidence of PJF was greater for patients that had no focus on implant prophylaxis or those that did. As you can see, with implant prophylaxis alone, the PJF incidence was split in half from 20 to 10%. However, if you look at the revision rates, they were similar between those two groups at 8 and 6%. So let's break it down into the individual prophylaxis categories. So the incidence of PJF with cement was 12%, with a hook was 7%, and with a tether was 16%. The hook being the greatest difference in lower incidence compared to having no prophylaxis at the 7% versus 20.3. But again, similar to the previous comparison, the revision rates for PJF with or without any individual form of surgical prophylaxis were similar. Okay, so now let's talk about the alignment. So in patients with no surgical prophylaxis and just focusing on alignment itself, if there was overcorrection of the alignment, PJF was at 24.2%. Whereas if they had, again, no surgical prophylaxis, but were within the accepted and goal sagittal alignment parameters, PJF occurred at 13% of the time. So revision rates were also greater for patients who had overcorrection of their sagittal alignment. So now let's look at the rates of PJF failure with implant prophylaxis and considering sagittal alignment. So if they were overcorrected and had some sort of surgical implant prophylaxis, PJF occurred at 11%. And if they were corrected to within their goal, 10%. And then the surgical revision rates were also similar between those two groups. So if we look at all of these groups together, the group that was overcorrected with no surgical prophylaxis had the greatest incidence of PJF, and that was 24%. So if you look at this Kaplan-Meier curve, those patients that had overcorrection and no prophylaxis had earlier PJF, and they had worse PJF survival-free durations compared to all the other cohorts. So at the end of the day, what does this mean? So the use of surgical implants alone was actually less effective than combining the use of implants and trying to avoid sagittal overcorrection. So patients that did the worst or had the highest incidence of PJF at 24% were those that had no implant prophylaxis and they were overcorrected in their sagittal alignment. So again, we know that PJK is a radiographic phenomenon. So obviously the severity can range anywhere from asymptomatic kyphosis to a catastrophic failure. But it's important to remember that we should focus on these age-adjusted sagittal alignment goals because it may reduce PJF as effectively as the use of surgical implant prophylaxis alone. So at the end of the day, the ideal PJF prevention, as proposed by this study, is to focus on the use of prophylactic surgical implants while paying attention to try to avoid overcorrection with the age-adjusted sagittal alignment. Thanks.
Thanks, Phil. So I see some questions coming in through the chat room, and I really appreciate it. We're going to address them probably after the presentation of this third article before we get to our cases. So to finish it off, Saurabh?
Yep. Okay, thank you to the Seattle Science Foundation for allowing me to present this article. So, So this article is from the ISSG. It's about choice of upper intramental vertebrae between the upper thoracic versus the lower thoracic spine. So this decision there's a variety of reasons why surgeons would either choose the upper thoracic versus the lower thoracic spine. It's the strength of the construct, trying to avoid proximal junctional kyphosis, maintaining range of motion for patients, as well as reducing the time of operation, blood loss, and any potential intraoperative complications. Really, the purpose of this retrospective study was to find out what the demographic, radiographic characteristics, and surgical characteristics really influence the choice of upper thoracic or lower thoracic for the UIV, and also to evaluate the outcomes associated with either of these choices. As I mentioned, this is a retrospective review from the ISSG, so this is obviously a large group of surgeons and surgical centers that are doing a lot of deformity surgery. They use standard definitions of what deformity was for these patients. And obviously, if you're deciding between upper thoracic versus lower thoracic, you're talking about patients that are fused from the sacrum/ilium all the way up to the lower thoracic or upper thoracic spine. This study collected classic sagittal and coronal alignment parameters, as Virginia discussed previously. They looked at HRQOLs, clinical factors, the rate of PJK, PJF, pseudoarthrosis, and rod fracture rates. So 303 patients were included, 169 in the lower thoracic, 134 in the upper thoracic. And what they found was basically, in summary, was that if somebody had a worse starting out deformity, surgeons typically went out to the upper thoracic spine. If they had greater preoperative Cobb angle in terms of their coronal alignment, greater thoracic kyphosis, they were found to they were more likely to get an upper thoracic UIV, as well as if the change in SVA was larger. Obviously, you need more strength of a construct then, and therefore people were more likely to go to the upper thoracic spine. Again, if you're doing a 3-column osteotomy, you're trying to achieve more correction, so you need a stronger construct. And once again, one of the significant findings was when a 3-column osteotomy was needed, surgeons were more likely to go all the way up to the upper thoracic spine. But it's important to note that some of the other findings of going up to the upper thoracic spine, which is that you get more operative time and you have increased blood loss. You had lower rates of PJK, but not necessarily PJF, which is obviously important if you're talking about PJF in the context of taking somebody back to the operating room. And also, there's no difference in HRQOLs, pseudoarthrosis, rad fracture rates, and reoperation rates, and overall complications. So, in evaluating all these articles, it's always nice to kind of take a broader look at what we're looking at here. So these are important questions. Obviously, whether or not to fuse somebody to upper thoracic versus the lower thoracic spine is an important surgical decision-making process that a surgeon has to go through. But I think this study points to the fact that a lot of this decision is done sort of by a case-by-case basis, where a surgeon is kind of looking at what they're aiming to get to, whether it's age-adjusted parameters or the quality of bone. These are all multifactorial decisions which are hard to quantify in one paper, although I commend the authors for their effort and for what they have delineated out. Also a really important question to ask for all these papers is, how will this change my clinical practice? And I think this further corroborates what, is sort of intuitive for a surgeon, that if you have a larger coronal deformity, a larger SVA, you'll likely need to go to the upper thoracic spine. But you do have to take into account that there's going to be greater blood loss and operative time. And obviously, there's some limitations. You need to have more data to define an algorithm for UIV selection, and that there's a heterogeneous decision-making process when you have such a large group of patients with such a large group of surgeons. And just another sort of food for thought thing that this article made me think of was whether it pushes us to think about create new ways to approach this problem, incorporating things like artificial intelligence or complex algorithms to take into account all the myriad of factors that an experienced surgeon looks at when deciding whether or not to go to the upper thoracic or lower thoracic spine. So, any other thoughts? And thank you for allowing me to present.
Thanks, Orb. So, now we're at the phase where we could either talk about, we could go through our cases really quickly before we address questions. It seems like there's a lot of questions coming in. So maybe what we'll do is go through 2 of the cases really quickly, and then we'll start our panel discussion. So the panel discussion is going to include some of our panelists from HSS who are on the line: Dr. Lafage, Vin Sandhu, Shiraz Qureshi, Todd Albert, but we also have some other HSS members here: Shevia Iyer, Dr. Patrick O'Leary, and I think that's it. So, I guess James, you want to start with the cases, or Michael, start with the cases? It seems like yours is up first. You're on mute. Mike, you want to unmute? There you go.
Good to go. So this is a 50-year-old female who has a BMI of 23. She presented initially to our clinic with complaints of lower back pain, also difficulty walking. She had a prior L2 to S1 at an outside institution in March of 2017. Her biggest issue now is that she's having progressive back pain with walking. She's also having some new onset left lower extremity pain that radiates to her thigh and somewhat into her groin. But kind of her biggest complaint is also she's feeling that she's hunched over. She's seen a couple other physicians. She's exhausted conservative measures, including gabapentin, physical therapy. Past medical history really is only significant for acute macular neuropathy. She had bilateral carpal tunnel releases and was a former smoker, quit in December of 2019. And due to her acute macular neuropathy, she's on disability. So in physical exam, she's grossly kyphotic. She does have a balanced gait. She's fairly intact motor-wise, except for her iliopsoas, where she's 2 out of 5 bilaterally. Her sensation's also intact, and she has no upper motor neuron signs. She's 2 plus reflexes throughout. So this is an X-ray actually before her prior surgery. So this is before she came to us, and this is what she presented with the outside treating surgeon initially. And the reason why I bring this up is to look at some of her parameters. We've mapped these in SurgiMap, and you can see that her lumbar lordosis is about 20, and her SVA is roughly about 7. And if you look to the right in the middle, that picture demonstrates the age-adjusted alignment by that green line there, kind of where she should be in her positive SVA that she has as a result of her deformity. At that time, she was having some back pain, but also a lot of radicular symptoms that you can see in some of these foraminal cuts here with some of the stenotic issues she was having at that time. Again, this is all before kind of we saw her. So this is actually how she presented to us. Again, she was presenting more with issues with back pain, her cosmetic deformity itself, but more so the neurogenic collocation symptoms she was having with walking. You can see the focal deformity kind of right above her prior construct, about 50 degrees. Her global kyphotic deformity, about 84 degrees. You can also see that if you measure from L1 down to her sacrum, it's only about 22 degrees of lordosis. But if you add that right above at L2 down to S1, her lumbar lordosis is about 48. You can see kind of the overcorrection that occurred during the initial surgery and the resulting adjacent segment disease that she's now suffering. Here's just supine imaging, and this just gives you an indication as far as what gravity is doing to help us kind of give some correction to her deformity. And then also I've included her CT films here, mostly to demonstrate that she has no evidence of any non-union, no evidence of screw loosening. She does have some vacuum disc phenomenon above her prior construct at 1.2 and also 12.1 and 11 and all the way up to 10. Here's probably the most significant finding on MRI that we found, L1, L2, the significant disc here with essential and severe stenosis causing some of the radicular symptoms that she is having on exam. So just kind of thinking about her overall alignment and then the issue with her current sagittal malalignment, I kind of want to pose some questions to the audience to think about how and what you could do, both from kind of a osteotomy, pedicle subtraction versus posterior column, also upper extremited levels, kind of how far are you going to go, if anyone will use any tethers, and also kind of what are you going to talk about the patient as far as post-op counseling or pre-op counseling and what to expect.
So Mike, for the sake of time, because we have a lot of questions coming in, why don't you go to show what we did?
So you can see here, this is the follow-up films. We did a T5 to the pelvis posterior spinal fusion. We do have T3 to T5 tethers that were incorporated into the construct. We did an L2 pedicle subtraction osteotomies with multiple posterior column work from about T5 to T11. You can see here just some of the quick parameters that we have showing our overall alignment and kind of her sagittal profile.
This was Dr. Schwab's case. Frank, do you want to make any comments?
Yeah, I mean, I think these are challenging cases, and who knows what set her on the wrong path. I think a little bit of an aggressive correction in the lumbar spine that put her at 48 to 50 degrees. She collapsed so that the L1 to S1 now measures 20-something, but I think a little too aggressive for what she needed, and therefore pertinent to all the discussions that we had prior to this. I think once addressing it, lots of different ways to do it, and many people would have gone laterally or anteriorly or historically. When I trained, it was all anterior, posterior, but I think we've gotten more elegant posterior approaches. She's got posterior stenosis, and so the idea was to take out the disc and then to benefit from getting bone-on-bone contact by essentially doing a decancellation. So it's sort of a grade 4 osteotomy through the pedicle up into the end plate above, removing the end plate disc and therefore the stenotic area, and getting good bone-on-bone contact. I don't think it's the only way to do it, but an elegant way to get bone-on-bone in the front, get a very controlled correction coronally and sagittally. As you recall, she was off coronally a little, and certainly sagittally. And so this is how we do most of these cases now, and then tethering them above. So she's holding up well. She's very happy so far. But one sort of newer approach, I think 10 years ago we wouldn't have done this way.
Frank, this is Vin. How often do you see this? I mean, there's so much fear among surgeons of inadequate correction of these deformities. How often do you see overcorrection like this?
So I think overcorrection we unfortunately see a great deal of, and it's just more subtle than it used to be. We used to be afraid that we got overcorrections from big osteotomies, but we're seeing many more overcorrections for degenerative pathologies through lateral and posterior work, a lot more lateral work. And I understand the enthusiasm with lateral work. We get great fusions, you get good surface area. But if it's not in the context of the patient's pelvic morphology and their age, we're unfortunately seeing a lot of these degenerative pathologies turn into age overcorrected patients that then sometimes just settle on the top, and they can tolerate that reasonably well, but sometimes these catastrophic failures like we see here.
Great.
And I would say, like, this patient was on the lower side in terms of pelvic incidence. So you're more likely to overcorrect a patient that have a small PI because they don't need a lot of lordosis. So in this population of small PI, we have a tendency to see more overcorrection than on normal PI or IPI.
Hey, Hanjo, we've got some great questions in the chat room. I'm afraid we may not have time for them. Any of them do you want to just go through quickly? Some of them are quick answers, I think.
Yes, absolutely. Yeah. Great idea, Vin. So
it starts with 828.
So maybe we start out with Vince Arlay's question. Vin, I didn't forget you. So this is a question. He said, in view of a very high neurologic deficit, do the authors change their practice and do more ACR than 3-column osteotomy when it comes to something that's a feasible approach? So maybe we could open it up to all the panelists to kind of chime in on that. I guess this is in reaction to the SCOLI risk data.
Yeah, Hanjo, I was just going to say something to it. So it's interesting. We enrolled a number of patients. A bunch of those patients are mine. There were patients that we detected neurologic deficit, and the patient was not aware of it. Crazy as it sounds, that they said, well, I was so functionally impaired before. Look, yes, you're telling me now my ankle's weak, but I'm actually functioning pretty well. And they're still grateful with their progress. The other is, I think that a lot of the PSO patients get either a stretch or some bleeding to the psoas anteriorly, and they do get hip flexor weakness for a certain period of time. That's picked up as a neurologic deficit, and in fact, the vast majority of those recover. And if you look at the SCOLI risk data, I think 50% of those patients recovered neurologically. So I'm not sure all of it is neurologic. Some of it, at least when it relates to the psoas, is due to osteotomies and stretch as you correct those patients. So I think we just need to take that into consideration.
Yeah, also, as a follow-up to that, there was also a similar study that was done through the ISSG looking at neurologic deficit rates, and it was very similar in incidence, around 20%. But the rate of recovery was very high. So the permanent deficits was somewhere between 1 to 2%, as opposed to the permanent, the permanent deficits were somewhere between 1 to 2%. So most of these are transient deficits, like Frank was mentioning, like hip flexor weakness and some radiculitis, for example, and things like that. So I think that's the number. It looks very high, but in actuality, from a functional perspective, it's a bit lower.
No, I haven't seen a number of those patients get hip flexor weakness, and it's not actually neurologic. I would say it's a little bit like the transpsoas lateral approaches where the psoas gets dinged, it's a little painful, and they can't maximally contract it. So there's a perceived weakness. It's a functional impairment, but I'm not sure it's always neurologic.
Yeah, I mean, the thing with the SCOLI risk study is that they were collecting the LEMS score on everybody at the time of discharge from the hospital. So if it was weaker than pre-op, they automatically counted it as a neurologic deficit. But those were not really true neurologic deficits.
Hey, Hanjo, an extension of Vince's question was, and I think it's a good one, was when you look at the CT scan, and I know I'd like you and Frank potentially and anybody else to comment on this. When you look at the CT scan and you see the correction you can get with just gravitation, with just gravity and positioning, I think his question was, why aren't you just decompressing, doing the disc, doing a T-lift, and fixing it? And maybe Frank or you could comment on using those supine films and judging whether you really need to do an osteotomy versus just a decompression and nail the patient in where they lie after positioning.
Frank, you want to expand on that because that was your case?
Yeah, so I think on that case that we were highlighting, the patient did not fully correct across that area, and the correction was through a huge gap disc, but even then was suboptimal. So actually started with, grade 2 resection, basically a Ponti type resection, complete facetectomies, and it didn't quite settle. So you're right. You could say, you know what, it's pretty good, and let's pack some bone in there, do a TLIF. But quite honestly, by the time you've done all that work and retracted things and you're ready to put it in a cage, to then sliver off the pedicle into the end plate and pack morselized bone, to me, isn't much more work, nor is it not more risk, but certainly you get a huge amount of bone-on-bone contact and the additional correction, those additional 10, 15 degrees that I think may make a difference. And so you're right. If you had done a grade 2 resection, and there are cases where we walk into the OR, as you know, Todd, and you've been your respective ORs, and we change our plan a little bit. We may plan for grade 4 resection, grade 3 resection, but by the time you've done all your smaller level osteotomies, you get the correction you need. You have a mobile spine. Of course, you're not going to do it. So I think there was the backup plan was let's just do a TLIF or pack some bone, but you just didn't quite get that correction. So in this case, I think once you're there, to sliver off through the pedicle and the end plate was just worth it.
All right, great. Next question is from Jens. For complication assessments, previous studies have shown that retrospective hospital-based surveys routinely underestimate actual complication rates. Do we keep track of complications with a dedicated FTE on a prospective basis? So maybe Virginie could comment on that, but before she does, I do want to say, yes, that's absolutely true. I think Mike Kelly has demonstrated that you basically half your complication rate when you do it retrospectively as opposed to going prospective. And I think definitely having a dedicated FTE on a prospective basis is very helpful. I know for the study that I presented, we do have somebody whose name is Tom Ross. He sometimes very overzealously reports complications. Sometimes he asks me, "Oh, Miss So-and-so had urinary retention. Is that a neurologic complication? Did they lose bowel and bladder function?" I said, "Oh my God, please, it's just related to the Foley issue. It's nothing really." So yeah, we do have that, but maybe Virginie could expand a little bit about that for us.
I think like you answer perfectly. So we have a full team of people that track everything, and I tell them don't ask the surgeon if it's a complication, just report it and ask later.
Yeah. So sometimes when we do the audit, that's when I come across things like neurologic complication rate 80%. Oh my God! You've realized that 90% of them are Foley related issues, and so anyway. So I hope that answers your question, Jens. Next is, again, Vince Arley had a question. Was the site of correction of deformity, does it have any influence on the incidence of PJK and PJF? And that's in reference to the paper that Phil Louie presented. So maybe, Phil, you could chime in on that study, looking at whether or not the correction of the deformity, where the correction was performed, if it had any influence on the incidence of PJK or PJF.
They looked at 625 patients. So on a collective basis, it's hard to sort of quantify that. So it's sort of aggregated.
So this was not specifically addressed in this paper, but other publications from the same group demonstrate that if your correction is too high, so the classic like L3 PSO, or actually we saw that in our database that a lot of the correction is like from L1 to L3. And the L4 to S1 is not really corrected. And on those patients where you tend to increase the lordosis in the proximal segment of the lumbar spine, this is a risk factor for increased rate of PJK. So yes, you're perfectly correct. If the correction is too high, then you increase the risk of PJK.
Great. So actually, we have about 5. Frank, did you want to say something? No. No, okay. We have about 5 minutes left. There's a lot of questions. So the question is, maybe I'll do a live survey here really quickly. We have another case. We could either get to the case or get to the questions. The case is interesting because I think that's it's a good example of, it would be interesting to see everybody on the panel side here, the 43 of us here, if you would have changed your surgical plan based on what we saw intraoperatively. So maybe you want to get to that case, or should we finish the questions?
Why don't you do the case, Anjo?
Yeah,
Okay,
do the case.
Yeah.
Okay. Go ahead, Jim.
All right. So I'll be quick about this one. I'll get to the meat of it. Can we just share the perfect? I have control now. All right. So I'm James, one of the other HSS Spine Fellows, and we're presenting a case. Quick history on this patient. Patient presented with severe back pain and inability to maintain an upright posture. They initially had a surgery in 2015 for a schwannoma. The levels are uncertain because they had an additional surgery before they saw us. So our second surgery was for ASD both above and below her prior construct. She had an extension of fusion above and below T4 to pelvis. She initially did well, presenting with increasing back pain and kyphosis. Currently, she's unable to stand upright. She's instability in both her legs, and she's got severe back pain, requires the use of a walker at all times. So that's her main complaint when she's coming to us. Her past medical history is significant for a couple things. Number one is lupus. That's going to be impacting our post-operative course and on cell septum plaque. For physical examination, she's got severe thoracolumbar kyphosis. A motor exam, she's 4+ at a 5 on left quad and iliopsoas, but no other upper motor neuron signs. Sensory examination, she's got some loss of sensation in left anterior thigh and left lateral calf, but those are both related to the schwannoma resection that she had previously, and there's nothing changed since her second surgery. These are her PA and lateral EOS films. I'm going to zoom in on each of these individually in a second. And you can see here her pelvic parameters, her pelvic tilt. She's got maximal pelvic tilt for her incidence. She's got 42, tilt PI of 40, and lumbar lordosis of 0. Her mismatch is obviously 40 at that point. Her SBA is also 16 centimeters. Her kyphosis is significant through T10 to L2, where it should be theoretically 0. She's at 79 degrees of kyphosis, and her maximum kyphosis, global kyphosis, is 112. We talked about supine images before. This is her supine scout image on her CT. You can see she's moving somewhat through. She's got a pseudoarthrosis and broken hardware that you could see. She's moving through T10 to L2 somewhat, but her global maximum kyphosis is still 82 degrees. And for her PA, you can see that she's slightly off to the right. Her right hemipelvis is slightly elevated, but most importantly here, you can take a look at the iliac screws, the trajectory of those, that you can really see that she's maximally tilted in her pelvis, and you take a look at her pelvic shape. You could appreciate the significant pelvic tilt even on this PA film. I'll skip this slide. Quick overview of the rod, where her rods are broken. And I'm going to run through these CTs really quick. You can see number one, this is at where the yellow line is. That's at T10, T11. She's got a pseudo there. This is an axial T12, L1. This is on the left side over here. You can see she's got a pseudo. On the right side, she's got a pseudo as well. The purpose of this slide is to show at that same level she's got a laminectomy defect. That's from her prior schwannoma resection. And this is just a lumbar film showing that the pseudo is not throughout the lumbar spine, but it's at the adjacent level, T12, L1. This is her old MRI. The only reason I'm including this is to show where the conus is, because it's going to be important when we do our surgical planning. It's at T12L1. The newest MRI was not helpful. There was a lot of metal artifact that didn't show us much in terms of planning for the case. So her main issues is she's got a multiplanar deformity, severe kyphosis, and pelvic compensation. She's got a coronal shift to the right, and she's got pseudoarthroses. So I can open it up to possible discussion at this point. In the interest of time, I can also go to the X-rays of what we did, so we can talk about it. Dr. Kim, you think we should just go ahead to the X-rays?
Go ahead, James. Yeah.
Okay. So our treatment, what we did was we exposed T6 to L4, replaced all the hardware in the field, did a T12 BCR with a Harms cage and bilateral costal transversectomy. These are our final X-rays, and I'm going to show you the parameters here. So at the end of the case, these are post-op standing films. Her T10 to L2 kyphosis was 10. Her lumbar lordosis improved to 22, which gave us a mismatch of around 17. her coronal deformity was addressed via the BCR. And then these are the post-operative comparison, preoperative and post-operative films.
So the interesting thing about this case was that when we started working on the fusion mass posteriorly and working through the pseudo, there was a period where I think the ALL had ruptured and the correction was essentially there, but there was a huge gap anteriorly. And we were trying to decide, do we just continue with the VCR here, because we were already exposed to skeletonizing the pedicles and basically an SPO above and below. Do we just instrument in this position and then come back and do an anterior and just put a graft in, or do we just do it while we're there because we're already exposed to the pedicles? And in this situation, we just continued on with the VCR. But if you see the AP X-ray there, it's probably like a 4 or 5 centimeter cage that was placed in the front. So I think a lot of people might have decided it was to come back another day, or maybe not. It'd be interesting to see what people's thoughts are.
Hanjo, this is Mike. Can you guys hear me? I pop the ALL a lot. I've only had to fill it in the front once. Usually I will just pack a whole bunch of bone in, especially if you can treat it like a burst fracture where you've got a bunch of screws above and below, like you would at the thoracolumbar junction. So for this case, I probably would have done an L4 PSO and popped the, I probably would have done L4 PSO and popped the ALL in the front across that big pseudo with a cantilever.
Yeah, so I mean, I think the question is like, would it have actually healed? And my thinking for not wanting to do that was because the prior schwannoma resection, there was no posterior element bone, so I was concerned about that.
Yeah, I take the funnel almost like a costotrans and fill the disc space up just with graft and a little BMP.
Yeah,
and do like a costotrans so that I can try and preserve some of the joints, at least on one side, so that you do have some dorsal bone stock.
Yeah, I think that, I mean, it'd be great if James had the fluoro shot of how widely gapped this was, but I was a little bit worried about that, especially because her protoplasm wasn't so good and her being on Plaquenil and Cellcept. But I have had cases where I've torn the ACL, for example, the ALL at like L5S1, and I have stuffed it with bone. And I have seen it heal, miraculously, even though it's like a huge defect. But there, I felt a little better about it because it was like there was some posterior bone that I knew would heal with it. Good proximity between the L5 transverse process and the sacral ala. So some of these factors that obviously are going through our minds when we're trying to make a decision on what to do.
Yeah, I think I've got an L5S1 also that healed dorsally. It was one of the first Fred Sweet things that I did. I think those heal well because you get great lordosis and they stand up and the back's under compression. I was a little freaked out and tried to do an anterior and actually couldn't do the anterior because the front was so stretched that the chief of vascular said, dude, we're going to be at M&M if we keep trying to get in here. We're going to have something really bad. So we had to abort doing an anterior to fill it in.
Yeah. Any other comments from the panelists?
Hey, Hanjo, Scott Blumenthal had he had a non-clinical question that I think he should.
He's actually next on the question list. Oh, there's a couple more, but Scott?
Yeah, I've unmuted. So, Hanjo, this is in relation to your talk, and your talk was incredible. We could have spent an hour just talking on that. But one thing that stuck out to me is you made one comment that your facility wasn't willing to share their direct costs. And when we put together our bundled payment on artificial disc, we couldn't have done it without direct costs. And with a faculty, and this is to you or any of the faculty at HSS, as robust as you, I find it interesting that you can't work together with your hospital to get direct costs, if not for research, for clinical reasons. And anybody, please comment.
Yeah, Vin and Todd, if you guys could comment.
I can make a comment. They will share the direct cost if they're de-identified. They get very concerned in our market about competition and from insurers. So, for example, we're just finishing the Corey study with Zoe Gogawala, front back for cervical spine. Do you know that study? and you're trying to do a cost analysis. And we were the last institution, and I had to get the lawyers involved to do. They were willing to do it, but there had to be a lot of protection. So they are willing to do it, but not easily, Scott. And that's really why, because they're paranoid.
But I think for Todd, for example, like for that particular data set that I presented, there's really no way to de-identify the data because it's a single center. So, yeah.
Sure.
Ben?
Thank you.
Yeah. Vin, anything you want to add?
No, Todd said it correctly. I mean, we're beginning to delve into areas now where there may be a little more collaboration with the hospital, but he's right. They're so sensitive in our market with releasing some of that financial information. But as we get into bundled programs, we're going to have to sit down with them and talk about where the costs are and, you know, where the profits, if there are profits left over, where they get distributed. So they're going to have to change with the times.
It had a very successful bundle program in joints here, so they now have experience with it, but historically they have not.
So it's actually 9:07. I think we're past our time, and there's so many more questions. I think maybe.
Yeah, I have Hanjo, I have a recommendation. If the people at Seattle Science, if we can write a few blurbs on some of these questions, can they distribute it to the participants on the call today?
You sure can.
Yeah, that would be great. I know Terrence had a couple of questions about ERAS, and there was a quick question from Jens about the rehab, I believe, rehab facility discharges. And I could tell you that the majority of the patients are going home, so only 5% discharged to rehab facilities in the expedited pathway. On that note, maybe some closing notes from the administrative staff at Seattle Science Foundation.
I'll give you one from Texas. You did a great job. Thank you guys very much. We get a lot more participants every week, and it's because of the quality. So, thanks for the quality presentation and discussion. And Todd Albert's looking better and better. So it's all good.
Thank you. It's staying at home, Jack. It's staying at home. That's my recommendation.
I got it.
And don't forget to file for your CMEs.
Everybody stay healthy, stay well, and we'll see you Friday for Journal Club and next Tuesday.
Thanks. All right, take care.
Bye, everybody.
Thanks for watching. Hit the subscribe button for more medical content.